Okay, good morning, everyone. In the interest of time, I think we can start and then, people will join in as they come. My name is Farhan Yusuf, and I am the Chief of Party for the Frontier Health Markets Engage project, which I will talk a little bit about shortly. And today we have a panel discussion that is, panel discussion slash presentation that is focusing on issues of access to finance and sustainable financing with a slight focus on HIV, but more generally for the health sector as well. I believe you can see the slides. So, our tagline as a project, Frontier Health Markets Engage, is healthy markets for healthy people. What is the current state of health markets in the, generally? So the public sector health system faces many constraints and cannot meet the growing needs and market demand for voluntary family planning, HIV-related products and services, and other health products and services, especially in low and middle income countries. Now, I usually say that, we have very lofty goals when it comes to health, be it for sustainable development goals, be it for universal health coverage, and really the public sector and really any sector cannot do much for it on their own. Users in low and middle income countries are increasingly accessing health services through the private sector so that they are able to access what they need and what they want, but challenges remain in ensuring voluntary family planning and other health markets are resilient, robust, and capacitated to deliver appropriate, affordable, quality health products and services and information in a self-reliant manner. Now, a robust private sector is an inextricable stakeholder in driving and sustaining outcomes capable of moving countries beyond the need for assistance and really the buzzword of sustainability that we keep talking about, and offers much needed infrastructure, staff, networks, and other technical and financial resources to contribute overall to health systems performance. Now, it is important to note that when we are talking about private sector, the issues around financing and access to finance become quite important because the private sector needs that financing to thrive, to survive, and to perform. So, as a project, FHM Engage believes that strengthening health markets will lead to improved health outcomes. We use a systems approach to identify root causes of underperforming markets, and we work together with all the different market actors to co-design sustainable solutions with local market actors to deliver the lasting behavior change and outcomes that are needed to evolve health markets. FHM Engage is a 5-year project. It started in 2021 and it will go on till 2026. And to provide a bit of context about FHM Engage as a project. So FHM Engage is part of the family of USAID projects that support the private sector and have been doing so over the last 30 years. The journey just very briefly started with, back in the 90s with a project called Profit, and then over the years has, evolved through different mechanisms until FHM Engage that started last year. My foray into this space of public-private partnership was actually with the Shops Plus project that was the predecessor to this project, which is where I realized and I became a part of this, I would like to call a movement to engage the private sector and work together with everyone. Again, as an introduction, this is, we are a project that believes very strongly in partnerships. So in front of you, you will see our, partnership model and who our different partners are. It is a project that is led by Chemonics International globally, with Results for Development as a co-lead, a technical co-lead, and Results for Development is the office in Tanzania, is the manager of all the operations for Tanzania. We also have Pathfinder, who are a partner, and interestingly, they are having a session at this same time, which is quite ironic. And we have Zenesis, that is a technology company, and another 16 partners that are spread, across the continent and across the world for the work that we do. Of course, we also work very closely with local partners, and you will see some of them speak today in the discussion. This is, again, a slide that talks about how we do what we do. So really, our core focus is strengthening local health market systems, and our main results that we are looking for are improved market environment for greater private sector participation in the delivery of health products and services, and improved equal access to and uptake of high quality consumer-driven health products, services, and information. FHM Engage works to address the root causes of local market underperformance in the core market functions to create the necessary behavior change that catalyzes supply and demand and supports sustainable change. Now, what you see in front of you is a diagram that shows the 4 market functions that we focus on. Stewardship, which is very important to drive the agenda. Rules, regulations, and norms that are basically the procedures and processes that we use to get market systems working. Market information, the issue of data, which of course we all know is quite huge in the health sector and in other sectors as well. But then lastly, financing, right? As I mentioned earlier, for any market of a product and service to thrive, we need financing. Right? For us, because we are a project that works very closely with the private sector, access to finance becomes a very key issue and a very key concern, especially I personally think in an environment like our country where there is not much awareness about access to finance. There's almost a fear of taking loans or working with financial institutions. And we as a project are really trying to advocate for that situation to change so that more people or more entities in the private sector can have the right kind of financing and be able to perform. This is especially important, and which is why we gave a sort of HIV-related angle to our presentation. Because HIV, as we all know, is one program within the health system in Tanzania that is highly donor dependent, right? And there's a lot of conversations that are going on about sustainable financing as far as HIV is concerned. Is, access to finance one way that we can have our private health facilities, our private providers be able to provide the necessary HIV services? We did have some more HIV-focused panelists today, but unfortunately, due to some other commitments, they haven't been able to make it. But I think the topic still applies more generally for the health sector, and we would love to have some time to discuss with everyone on those matters. Now, that is as far as the introduction goes. I believe we will have some time at the end for any questions. So please, if you have any questions generally about the project, feel free to ask when the time arrives. I will now hand over to our team member, a team member from the FHM Engage project, Deus Manyenye, who is our senior technical advisor for access to finance and health system and business strengthening, with a lot of experience working in the financial sector and now working at that sort of interface between the health and the finance sector. He will come and take us through the next section of the presentation. Karibu Deus.
Good morning, everyone. Right, I'm part of FHM Engage, which is under RFD organization. As my colleague just spoke, Senior Technical Advisor, Access to Finance and Business Strengthening. Here I'll be able to take you through the issues in access to finance that is in this market, that you can be able to appreciate how this thing regarding access to finance has been taken up by the financial institution in the market. As you know, the health facilities, in order to be able to provide effective health services, they need funding. Of course, there are a lot of needs for those funds. They will need to have the right infrastructure so that they can be able to provide effective financial health services. So I just want to highlight about the health sector growth worldwide, just to appreciate how it is going in terms of growth. On average, the health expenditure has grown by 5%, And of course, the global spending on health account for is approximately 6% of global GDP by 2021, and this is sourced from the health expenditure OECD information. So the reason being the population is growing, as you can see, almost 7.9 billion world population is grown by 0.83%. And of course, Tanzania alone is grown by 3%. So there is a growth in population that is putting pressure for more health services in the market as well. So another one is economic growth. In the world is growing by 2.2%, 2021, and of course in Tanzania is about 4.3%, and it's actually expected to grow even further between 4.5 to 5 this year as it is projected. So it is, you can see when the population is growing and the economy is growing, there is a lot to do with health services provision. The others are raising consumer income and corresponding ability to purchase healthcare and the extended life expectancy. One presenter here in the morning was talking about there is improved life expectancy in this particular country at the moment. I think it is something which will also demand for more and effective health services. And of course, shifting disease burden, which also is growing in some areas. And so on. So on access to finance, I will just talk about the supply side and the demand side, particularly in this market. If I might skip that one. Let me start with the supply side. We know the players in the market in terms of provisioning of loans to health facilities. They are the most known, that is commercial banks, of course, followed by microfinance institutions. We have got government in a way, also coming up with NHIF is also part of the institution that are actually giving loans to health facilities. Then there are others like basket fund and other subsidies are being provided by the government. Other donors and international financial institutions are also players. Of course, out of these, commercial banks are actually key in provision of funding or in terms of giving loans to health facilities. Not very much microfinance, very few are doing, but there is, I know Afia Microfinance is dominant for that. It's actually is known for giving loans to health facilities, but of course it is a small microfinance. It's not across the country. It's only in Dar es Salaam and a few other places. But we would expect commercial banks to be the most dominant kind of financial institution that will be giving loans to health facilities. But of course, what is the situation at the moment? There's very, very low focus. If you compare with other sectors, the loans that are given in health sector by commercial banks are very, the portfolio is very small. There's no bigger focus. Most of the banks, except a few, have even health loan facilities in their portfolios. They just have that other product, and then when an application is coming through health sector, they just take it as any other loan. So they do have this one size fits all. But in this sense, that is not the case, supposed to be the case. If you really want to focus on a certain product, like in this case, health sector, you really need to have a tailor-made product. So if you don't have a tailor-made product for health sector financing, then you still not have a adequate focus on it. So same like any other products in the health in the commercial banks, which have got focus, they have got tailor-made products, they have got dedicated RMs, they have got specialized personnel that are dealing with those kind of loans. But for health sector, you go into these banks, you will never find a dedicated product that is a health loan product that has got specialized people are focused on that, have got the special skills to even be able to analyze and do appraisals for those kind of applications. So it is a challenge. That's why you find that it's still much very much in the low side of the focus of the commercial banks. They lack specialized skills, as I've said. If you go in, if you happen to go and in those banks, you find product like agricultural lending product, you'll find specialized RMs for agriculture. If it is equipment financing, you find the same. If it is construction, you find the same. But when it comes to health sector lending, there are no specialized people in those banks, except a few. CRDB is here. They can't talk otherwise. And I know we are working with CRDB for almost since 2014. They might be a little bit different in terms of the approach, but in most cases, that is a big challenge. So again, I find it some relevant products for health sector lending, something like invoice financing or invoice discounting is not highly highlighted by most of the banks. I mean, there is a big challenge, I would say, maybe it's now improving to some extent, but there's a big challenge when it comes to payment of invoices that actually been lodged to NHIF. Sometimes it takes 30 days, up to 180 days to get paid. And these facilities, they really, before payment, they really struggle in terms of working capital because their money has been tied in those payments which are supposed to be paid but are getting delayed to be paid. So invoice discounting is the right product for that. I would expect commercial banks would have come up with invoice discounting products and then be able to create awareness for that, and they can be able to address the issue in respect of delayed payment by NHIF of those invoices. But again, I would say lack of incentives from the key stakeholders, particularly government. I have been a banker for most of my time. I see there are some focus areas that the government has, and of course it takes even time and even sometimes creates some incentives like guarantees. For instance, agriculture, it has got some special arrangement with the government. You would have heard a few days ago the subsidies that are coming in. SME has got even special SME guarantee by the government. There are some other guarantees that are actually being put in place by the government to support some specific sector in the country. So health is that huge kind of, and that is very important sector. I would expect that the government will step up and say, well, we have to arrange a certain guarantee for the lenders to be able to be encouraged to give loans to the sector. You understand when we're moving around, you find there's a lot of startups. The doctors want to come out from the employment and start their own clinics or their own hospitals. The graduates, young graduates, they also want to do business. They want to form pharmacies, clinics, and other things. But the biggest challenge is access to finance. The capital is the problem. So incentives like maybe coming up with some up like the guarantee for startups, the guarantee for freshers, doctors who want to start their own facilities, it would have played a big deal to support the lending in the health sector. Okay, one would ask what is opportunity and what is the size of the market that is in there. So I look at the private sector, the dispensaries and health centers and hospitals. According to the study that was done by Shops 2016, some time back, it indicated that there is about 1,821 dispensaries, health centers, and hospitals. And others, for those who, I believe I'm talking to you, you're almost in the health sector, you know others. Accredited drugs dispensing of outlets. There are over 10,000 in the market, and they're getting registered day after day. So the number is growing. The pharmacies and other services are there. So this is a huge market for commercial banks to see as an opportunity for them to grab and be able to provide lending mechanism to them. FBOs, the over 900, these are under CSAC, there are over 900 as we speak. And of course, the number is growing. So these are huge opportunities. And when we spoke to them, 84% of them indicated they want credit. So 84% of this is a big number, and surely it needs support. So looking at the constraint that they have, I wouldn't talk all of them, but specifically lack of access to finance. This is number 2 there. 69.8% are saying there's a limiting aspect in terms of them getting access to finance, so they are not able to get finance from financial institutions. And I talked in the previous slide about the NHIF disbursement. If you break down into private and government, you find almost 69%, nearly 70% of disbursement for NHIF are going to the private sector. So if you are a bank, you find this is an opportunity to go and create a very good loan for them to have access to it. Again, supplier credit is another area where health facilities can be able to discuss and be able to strike deals so that they don't pay upfront. They'll be paying according to a number of days, credit days that have been given. Of course, from these statistics, you find that 30 days are quite normal. So arrangement and 30 days to pay are quite normal. Of course, 50% of the facilities have got no supplier credit arrangements in place. And this is an opportunity if they will be able to discuss with the suppliers that they could be able to have sufficient money at least to do some other things when they're waiting to pay in 30 days or 60 days or 90 days. Let's go on the issue of the uses of the loans that this facility need to. You find that 32% they are talking of expansion. They want to expand their facilities. Basically, they want to have best infrastructure, physical infrastructure for them to be able to provide effective health services. So 27 is on equipment, purchase, and et cetera, et cetera. The figures are talking by themselves. But what is important here is that, the commercial banks and the other lenders in the market, they can have an opportunity to finance expansion of facilities by these health facilities so that they can be able to expand and be able to comfortably serve the community. Equipment is an issue. It's not a big issue, but it's an opportunity again by itself. Last 2 years back, we had, as FHM, then it was Shops Plus, we were able to arrange MOU with a bank that we're working with for the equipment suppliers to be able to guarantee these loans. They arranged what is called buyback agreement. So a bank can be able to issue loans disbursed through these equipment suppliers. The suppliers will be able to supply equipment to the facilities, and then they guarantee those loans. So upon default, they can be able to pay. This is a very good arrangement, very effective arrangement, because now the facility will never struggle to look for securities to be able to access loans, especially when they want to purchase equipment. So I'm challenging the commercial banks and the other lenders to explore that route. That's an opportunity for them to do business with these health facilities. So on the issue of securities, which is the most talked about, I cannot get a loan because I don't have securities and et cetera, et cetera. But when we did a study those years, 2013, 2016, we realized that other than CSSC, which are FBO facilities, most of them have got lend. Of course, I know commercial banks, they don't accept a bare lend without having a property on it. So, but at least 23% of them have got lends. I know CRLB are talking about non-traditional security, which is basically lands. They can accept lands as part of securities on small deals. As an opportunity for them as well. But you see, 53% said to have got buildings and the private sector pure, which are non-FBOs. They have got buildings which now the issue of security is no longer, if you really, for 50% is a big number. But the situation is quite different when you go to FBOs. You see most of them, they have got, they would prefer guarantors as security, 43% of them. And the buildings, 90%. It's quite a different scenario altogether. And I'm not surprised because imagine a facility built under the church premises. You know, a title is one, it's a big, 3, 4, 5 acres. One title deed, and of course the buildings are within. You cannot, the commercial banks cannot be able to take that as security because you cannot realize it when you need to realize that particular security in case of default. So for them, they are kind of struggling. They need a separate arrangement if they have to have access to loans with commercial banks. And the best idea for them could be the equipment, the buyback arrangement, plus the guarantee, if any. So let me finalize with this a good slide, which reason for none wanting a loan. Of course, not all. You see this particular sector, you're talking from the supply side and from the demand side. It's something like new. The supplier side are just now coming up, seeing this as an opportunity, which they never saw it before. So they are now trying to align their house so that they can be able to take this opportunity. Training the staff, probably trying to come up with certain tailor-made kind of terms and conditions, trying to accept, but still something they're learning. So they are not very much into it. Again, when you come to on the side of demand side, the health facility owners, first of all, they never thought they can borrow and do business and be able to pay. They thought they're in services industry, so they're not very much in business. So they kind of hesitating borrowing because they are not sure they can be able to pay. So, and of course, the issue of interest rate has been very much high on the agenda. That interests are very high. For instance, at the moment, my colleague Rehema will just talk about it. But if you talk about the industry, you're talking about between 18 to 25%, somewhere in between. I mean, this is very much on the other side. If you really want to support a health sector, you have to consider about coming with lower interest rate than this to be able to encourage them to pay. But again, the interest rate is the interest rate is basically as when charging high interest rate is the factor of risk in the way. So some commercial banks which are in this space, they think health sector financing is of high risk. Our experience is different, altogether is different, because over the time that we've intervened as FHM engaged in those days was shops, we found that in health sector, default rate is actually under 10. You're talking about 5%, 6%, regardless of anything, which is just very much the lower side. So it is an opportunity for them to go ahead. But again, they're still charging a very high interest rate. So I think it is something that they can think and reduce that rate so that they can encourage borrowers to come. So what has to be done? I would say stakeholders to work closely with financial institutions, the government, private sector, international organization, craft something that can encourage financial institutions to borrow. And again, they should consider providing incentives, especially government. That, as I've said, there are so many startups in the health sector are supposed to start, and people are not able to start because they don't have capital. I've said the fresh graduate doctors, those experienced doctors, they want to come out and do their own businesses or set up their own facilities. They are struggling to do that because there's no way they can access capital. So if there is any some sort of guarantee for those from either the government or interested partners, it could be easy for them to start a business. So we need to have information, education, and customized products. As I've said, tailor-made products are very important. You cannot have one size fit all. I mean, each particular sector has to have its own terms and conditions because they are different. So I urge commercial banks to be able to think aloud so that they can be able to take opportunity on the health sector financing. Thanks so much.
Thank you so much, Deus. Dadarema, while I introduce you, I think you can set up just so we save some time. So next up, we have, we are having a conversation on access to finance, and I think that conversation would be quite incomplete without us having a financial institution here amongst us. And so we were able today to get, CRDB, who has been a partner for Shops Plus as a project in the past and for FHM Engage now as well. And so we have from CRDB Bank, our colleague Rehema Mhina Shambwe, who is the manager for product and special projects, including Women Access to Finance Initiative. So, very much interested in specialized products. Her work experience, she has worked at CRDB Bank for 21 years in various positions as, relationship manager at corporate department, senior relationship manager for SMEs, manager Women Access to Finance Initiative, and currently a manager for products and special projects. She is well experienced in women empowerment, access to finance since 2012, and that I think is quite interesting because when we are talking of many of these private sector health facilities, especially those that are at the last mile, at the grassroots, whether we are talking about accredited drug dispensing outlets, many of them actually are women-owned and, they're women-owned initiatives. So she has a lot of experience in that space, and I think there might be a lot of questions. Her experience in specific areas includes products development, portfolio management, capacity building to different staff members, managing partnerships, customer training, and inspiring and coaching medium and small enterprises, women, and youth through various platforms. Karibu sana dada Rema.
Thank you very much. Thank you very much, Farhan, for your good introduction. Yeah, I'll split it. Good morning, ladies and gentlemen. As I've been introduced, my name is Rehema Shambwe from CRDB Bank, and I'm very happy to be here to share what we have at the bank in terms of access to finance to health sector. And over time, we've been working with our partners, FHM Engage and Shops Plus, but also with the USAID, assisting us to penetrate and reach out to health sector. So today I'll just be sharing what we have at the bank. Sorry for the technical hitch. I'll just, I think there's no compatibility between my devices and the forum. So I'll just continue without it. Basically, as a bank, we do value a lot the health sector. And amongst the sectors that we work with or try to empower and reach out is the health sector. So basically, we do have partners that we work with. As I mentioned, FHM Engaged, USAID, and others that are supporting us to reach out to the health sector. And we've realized as a bank that we need to be able to change ourselves or not to do the norms, because each sector has its own needs, each sector has its own requirements, each sector has its own targets. And as you know, before we just had a one shoe fit for all, but we came to realize that we need different products or different arrangements to be able to reach out to different sectors. And one of the sectors is, as I said, is the health sector. Under the health sector, we realized that, as my partner mentioned in terms of financing, that a lot of health sector are operated as just giving out the service, not considering that is also a business that has to grow, has to change, has to attract customers. Because as you know now, I'm sure any of you don't go to any hospital. You choose the hospital you go to, isn't it? And in choosing the hospital, it depends what you are looking at. Probably you're looking for a best doctor, qualified doctor, or experienced doctor, or you're looking for the facilities in that hospital. It could be the building itself, how clean it is, or how many facilities are available at that hospital. So in terms of individual owners' hospital, most of them, as I said, they were operated as just offering service because you're working as a passion. I know your sector is one of the sector that you offer service as passion or as wanting to help people around you or in the community. So we realized that we need to come together and make sure that we assist by talking to the health sector, facility owners, private, government health sectors, to find out what are the needs, what are the obstacles, why are we not seeing health sector or health facilities coming to us to borrow or to even ask for the products that we offer. Because you see other sectors like agri, trade, they're very high on the map, but health sector is very low. So when we realized that we need to engage, and we found out that most health sectors owners, they don't do it as a business. Therefore, we partnered with many partners, including the FHM Engaged, and again, the AO said to do the survey and to do the training to make sure that we are going to reach out to these health sector facilities. So I will just go straight to let you know that we are partners in the health sector. And since we've done these partnerships, we've been able to reach out to many health sectors, health facilities, including pharmacies and so on, by offering a lot of loans, different loans according to the need of the facility. And we structure our loans according to the need of that health facility. And therefore, we've been able to issue almost 28 billion in the health sector. We've been able to issue more than, we have pipeline of more than 100 billion in health sector. We've also been able to offer cash solutions to 144 health facilities, like purchase of point of sales, internet banking, and so on. So in order to improve the health sector together, as I said, it is our core business. So we also offer CSR for those who require maybe to partner. They don't want to borrow, but they think they have a good strategy. They have a good cause that they need to a partner to work with. So we also, through our CSR, We do education to the health sectors. We have been able to offer almost 260 million Tanzanian shillings over this year that has been spent on the health sector. We've also been able to issue loans of more than, we've been spent also on a CSR more than 300 million also through COVID and other communicable diseases. Our readiness is to enable the growth of Tanzania health sector. Therefore, the health sector lens, we've been able to look at the challenges, as I said. Health sector is perceived as only a social service and not a business. Many health sector professionals lack adequate financial knowledge or how we operate as banks, or what can they get as a bank, or they can put up proposals that suit them, and us as a bank, we can be able to adjust ourselves and be able to serve the health sectors. Limited knowledge on acquisition of managing products and services offered by the banks. Most banks have limited knowledge also, as I said, to be able to serve the health sector. Lack of collateral that has been mentioned by Deus a few minutes ago. This is in conjunction with social injunction. Limited medical supplies due to poor collaboration between financiers, suppliers, and hospital. Income leakages due to lack of payment processes solutions. Most health sector, when you go to them, you ask them, are you able to pay a loan installment maybe of 5 million per month? They will tell you, I cannot pay that. I've heard that there's a survey showing that also difficult in payment of the loans. It's because they have not been able to track your incomes, your outcomes, your cash flows, and so on. So we offer that solutions, and we've been able to work with almost 1,300 private sector health services and 10,000 accredited drug dispensing outlets, 1,000 pharmacies, more than 500 standalone labs we're working with, in 100 nursing homes, and also 6,900 public health sector facilities that we've been able to offer these solutions. Our main solutions here is investment and working capital challenges, to address working capital challenges and investment challenges. We do offer things like overdraft facilities. The overdraft facilities is for any health sector that can generate income, and you do borrow when you have a shortage of cash flow. Maybe within 3 months to come, you think your cash flow inflow will be low, so you require a loan to make sure that you're paying your bills, you're paying your maybe salaries, and so on. And this one can be structured up to 12 months. You don't have to pay within a short time. The overdraft is a 1-year maximum facility where you're able to borrow for up to, from maybe 1 million to even, it has no, it has no end, no maximum. Yeah, can borrow 3 billion, can borrow 500 billion, and so on. So, but it depends on your ability to pay back within that prescribed or agreed time frame. Maybe you're saying in a month I'll be able to pay 2 million, and so on. That will structure your loan according to what you are able to pay. And the interest rate for the overdraft facility, our interest rates are below 21%, but on reducing balance basis, you pay very little. But for overdraft, it depends on how much you are able to use the loan. Maybe you can borrow 100 million, but you see you're not going to use the 100 million at once. You may be able to use 100 million, maybe you draw down is like 20 million per month. The other day is 5 million, and then you get paid by your maybe health insurance or your customers. So you only pay the overdraft for the amount that you've spent. You're not going to pay the 100 million that you borrowed at once. So if you borrowed 100 million, as I said, and you withdraw 2 million, you only pay interest on the 2 million, not on the 100 million that you've borrowed. So overdraft is good sometimes because it gives you the ability to collect your debts, to do your business and bank your money so that you're not supposed to pay too much interest rate on it, because you have not spent that money if you don't need it. And caution is that when you have an overdraft of 100 million or whatever, 2 billion, 3 billion, only used for the purpose of overdraft. Most facilities, health facilities, fail because they ask for overdraft, but they see, okay, this money now is idle, sitting idle. They draw it and going to buy capital investment, maybe a machine, maybe a vehicle for the hospital, maybe do expansion in terms of buildings. So that money is supposed to be paid within 12 months. There are loans that are purposely for those kind of needs. And you're allowed to have more than one loan at a time. Don't limit yourself that you've got overdraft and then you say, oh no, I need to expand maybe to refurbish maybe a laboratory, so I cannot borrow. I'll use my overdraft. Don't do that, please. You just come, we talk, and we give you another second loan for capital investment or expansion or purchasing of the machine. Another solution we have is invoice discounting. Invoice discounting, we understand most of facilities are engaged or interacting with health insurances, where they say they'll pay you 60 days, they'll pay you within 90 days, they'll pay you within 30 days, and so on. We saw the survey there, most of them are 30 days. But some of the 30 days, they promise, but they will also delay and pay you a little longer. So when you have an invoice, you can come to the bank, present your invoice, and we can issue an invoice discounting loan facility up to 70% of your invoice. And that loan takes at least not more than 7 days, because we understand cash-based or transactional-based loan facilities, they have a specific need and they're very quick. So we only take a maximum of 7 days to issue the money that you have applied. So if you have a 100 million invoice, you've presented it to maybe NHIF strategies and so on, we'll give you up to 70% of that, which is 70 million. And that one is purposeless loan. You don't have to say you're going to do 1, 2, 3. It's just for your normal working capital needs of the institution. Yeah. And then we also have, you do give your customer or your vendors jobs to do. So you can also tell them also they can come and get local purchase order financing. Maybe you've issued LPO to someone to bring you maybe some kind of a machine or any other equipment that you need for the health sector. You can tell them to come to the bank, because we can offer them also up to 70% of their financing need to purchase the machine and come to supply to your facility. So this one also is like 7 days, and they can borrow any amount, and 7 days turnaround time, and they can pay when you pay them. Even the invoice discounting, when you get paid by maybe NHIF or strategies or any other health insurance, once you are paid, you pay us, or we deduct our money that we've borrowed you, and then you deduct our money that you've lent you, and then you remain with your profit, or whichever money that is not ours. And this is transaction-based, therefore there's no collateral, there's no security. The security is only the piece of paper that either is an invoice you submitted to NHIF or any other person you're working with, or the LPO financing, LPO document for your suppliers, as I said. There's no collateral for this. And the big, let's say the biggest thing you have to do is remember that once you get paid, we deduct your money, we leave you with whatever is remaining for you. Yeah. And also we have guarantees that maybe you've got, you need equipment, but you said, my bank, can you give me a guarantee so that I can procure this equipment from outside the country or anywhere, even inside the country? We can give you a guarantee if you're a very good customer of us, that you are channeling all your sales into a bank account that is at CRDB Bank, so that we know your cash flow, we know your turnover, we know your trend, in the account, so that we are able to guarantee you and you can procure or get whatever need you have. And also we have short and long-term loans. We have investment loans. These investment loans, as I said, their purpose is to invest something that is not going to turn your cash flow or to bring money in quickly. For instance, you're extending a building. That one will not give you money back very quick. It will take maybe up to 11 years to bring the money back, because it's the facilities that you're offering that will pay the loan and not the building itself, because you're not selling, you're not a guest house or a hotel or anything like that. So this investment loan, they can go up to 5 years or 60 months, but depending on your cash flow need, you might be able to pay within 2 years, 3 years, or even longer than 5 years, because you sit and assess your cash flow and you decide exactly how many years should we give it to you to repay the loan. And this cash investment loan, you can borrow even above 5 billion, because sometimes you're constructing a building, sometimes you're overhauling your hospital, your facility, or sometimes you want to buy equipment that will take a lot of money to pay. And for these facilities, of course, collateral is required. So your hospital can be a collateral, and some partners we are partnering with can also assist us to manage the risk. So whatever collateral you have, just don't be shy, just bring it in, let us know this is what I have, and we'll see how we can facilitate you, giving you the money to do whatever you want to do. And in this way, we can also apply or implement your project or build your building or whatever you want to do in phases to release the collateral requirement need. Because sometimes if you want to build building like this at once, the collateral requirement will be too high. But you're saying I'm doing in phases. Maybe I'll do phase 1, then we consider what you have as a collateral and what we can offer, and look at our partner, how they can manage the risk. And maybe you say second floor will be my phase 2. Then later on we consider what you've already built and as a part of the collateral, and so on. So you find out you can build a hospital like this building in phases, and we are able to facilitate you, get the money that you require to build the hospital or whatever facility. And this one is the cheapest loan because we said our interest rate are below 21%. So once you start paying the loan, our interest rate are applying on reducing balance basis. So if it's on reducing balance basis, it means you're paying interest on whatever is remained as a loan. Like a first month you pay, you've taken 100 million, interest rate will be applied on 100 million divided by 60 months. And then that 1 month portion will be the interest rate. And then as you're reducing it, the interest rate is charged on the balance of the loan. Therefore, you find out in the end you pay only 9% to 10% of whatever you've borrowed. If you took 100 million, you end up paying only 9 or 10 million as interest rate. Yeah. And for another facility is maybe equipment facility. I see most doctors now they work, but they have their own diagnostic facilities or laboratories and so on. So you can also come and borrow equipment like MRI facilities or equipment, or you can borrow even the dialysis equipment and so on. And then you can put it on your facility while you're working, but you can also have your own facility somewhere. Yeah. And that one is asset financing. We call it asset financing. You can only contribute 20% of the value of the asset that you're going to purchase. If it's an MRI machine or ultrasound machine, you can only contribute only 20%. And the rest, 80%, the bank will give you as a loan. And in some cases, that equipment can be as part of collateral. So you also release your collateral requirement needs. Yeah. The other maybe complex health projects also, we do syndication through our dedicated desk with vast experience arranging finance through local and international partners. We can do syndication if your need is too big. We cannot do it ourselves as a bank. We have partners that we can work with and be able to offer you the facility. Also, we have business operational risk, where we can do fire and burglary insurances, fidelity guarantees, and so on. But we also offer salary payment solutions. If you have staff in your facility, they do need to borrow, then we can do lending to those staff. We also offer internet banking for bulky payments and non-CRDB accounts also. We also offer instant accounts opening, and we also offer you the SIM banking account. So you need sometimes something like internet banking that you can be able to watch out your inflows and outflows through the account and manage it well. So our solutions also on staff welfare, as I said, is the loans, personal loans, salary advances, mortgage facilities, personal insurance policies, and so on. But when you borrow, as a key man person, we will have to insure you for credit life insurance in case of anything. We don't want to sell the building or start harassing the family and so on, so that the insurance can pay. We also have, as I said, cash management systems. We have these point of sales devices, the QR code, foreign currency transaction services, and so on. We also have partnering for adjustment services like Wakala and so on. So you will not fail to transact or to do anything at your hospital. Our commitment to the health sector is to foster more collaboration to enhance the health sector. Also is to partner with stakeholders in health to improve the availability of funding towards health and knowledge on the financial sector. So we also, as I said, we do training. Whenever we have training, we can source out and see how many people we have through our partners or through our branches that we can offer financial literacy training and offer either in-depth, communicate in depth about our product and services. So we also work closely with some medical insurance companies. We offer customized solutions. As I said, you might come there and whatever you have as a bank, it does not appeal to you. So we can work around what you have, what you need, and structure your facility, structure the anything that you need us to do for you. We also continue to invest in training. As I said, whenever you have a needed training, you have your staff needs training, you have maybe a group of people you're working with, maybe in the same sector, you need training, you can always come to us and let us know where we can structure and arrange and do training for your staff or your group of people that you do like businesses. Thank you very much for listening.
Thank you very much, Dada Rehema. I know we are running out of time, so I think you can take a seat just very quickly. I think the organizers will forgive me. I might go slightly over time because you also started late, but in a few minutes that we have, I'd also like, I think in terms of experience sharing, and maybe Ibrahim, you can do it right from where you are sitting. As we saw, there's a lot of, and I think for us as a project, one thing that we are really trying to push for is for the public sector stakeholders, the providers, the doctors, the health professionals to not be afraid of finance, right? Because it seems like that's something that's just there, it's habitual, and we are trying to, as you saw earlier in my presentation, we are really as a project trying to bring behavior change, and I think part of that is, just creating these bridges between the health professionals, the health sector stakeholders, and the financial institutions so that this fear is removed. Now, another case sort of study that we wanted to share on this panel is we have from Maisha Meds, which is a health startup, and I'll let the representative speak about it a little bit. But we have Ibrahim from Maisha Meds, who will talk to us about how there's some innovative financing mechanisms that we've been able to work out together with another bank, Amana Bank, who's also a stakeholder for FHM Engage, and really all financial institutions are. So Ibrahim, if you can just talk a little bit about Maisha Meds and the experience with that process very quickly. I give you 8 minutes.
Thank you. Good morning. Yeah, my name is Ibrahim from Maisha Meds. Maisha Meds is an international organization where we provide POS systems for ADOs and pharmacies to help them better manage their businesses. As we all know, these facilities are managing their businesses initially through local ways like pen and paper. So Maisha Meds is trying to digitalize all their operations of these ADOs and pharmacies. Yeah, so to speak of FHM Engage, currently we are in a conversation with Amana Bank, hoping to sign an MOU with them regarding providing access to finance to ADOs that we are working with. Yeah, the system that we provide is freely available on Play Store, but the cost for installation comes with the gadgets that are used to run the system. It's an Android-based system that is running through the tablet. So most of the ADOs lack the capital to buy these gadgets, and also they lack money to cover the installation cost for the team that is doing the stock taking and for the training. This is the one-time cost. So this is where Amana Bank comes in. Amana Bank will provide a loan to these ADOs, and these ADOs will pay that loan back to Amana in installments, and then they start using the system while we train them on how to, on entrepreneurship management, because most of these facilities, as my colleagues have said here, they are doing businesses as usual. They don't follow those norms of the businesses. You find that they are mostly doing these businesses for subsistence economy. The facility is doing everything in the family, buying the food, paying for the rent, paying for the school fees. So they don't follow those procedures like open the bank account, deposit the sales every day, and then withdraw from the bank account to go buy the inventory. So right now we are trying to mentor these people to change their perspective on how they are conducting their businesses, so that when these banking institutions come in, they can find them that they are creditable, so that they can access to these loans. So yeah, once again, we appreciate FHM Engage for taking this lead, establishing this connection between Maisha Meds, Amana Bank, and Pwamwao. Pwamwao, a little bit about it, is an association for Pwani, for ADOS Association, an ADOS Association from Pwani region. So this project, we will use Pwani as a pilot for 6 months and learn from that piloting period, so that then from there we can launch that through Tanzania. Yeah, that's a bit about that.
Thank you so much, Ibrahim, for being swift more than anything. I think as a project, just to share again with people, what we believe in is creating ecosystems and really bringing people together. As I said, in the past we have done under Shops Plus. We did some work again with an ADO association, a pharmaceutical supplier, and a financial institution, whereby, again, similar to the invoice, the invoicing that we have heard of, that the financial institution would give the loan against what the ADOs request to the pharmacy. The pharmacy would provide the necessary stocks to the ADOs, and the ADOs would pay back to the financial institution, with the ADO Association sort of playing the role of the middleman coordinating all of this. And now we have this other example that is not to do with is not to do with products, it's not to do with pharmaceuticals, but really is helping ADOs. And we know there's a lot of conversations around ADOs in the country at that last mile about how are they managing their processes and all that. So we see how access to finance is helping that last mile provider, private provider, to improve their systems and be able to provide better services. So really there's a lot of opportunity for us to be able to unlock this finance and use it to create better health outcomes for the country, for our health system, and for the people. Now, I know I had promised I would close at 12. Maybe if they can give me, 5 more minutes, if there are any burning questions. Of course, we'll be around post the session, so let's keep the conversations going. I really don't want to take too much time from the next session, but if there are any burning questions really quickly for anyone up here, maybe we can take one or two. Okay, looks like people are being shy, or it means that, the presentations were amazing. I think, since there are no questions, I guess, okay, I see one question. If we can pass the mic, please.
Yes, thank you very much for such enriching discussion. And now, my question would be, like, whom do you advise to take the loan? Is it the one who is going to consume the products or the one who is supplying the product? Like you have someone who needs the machine at the hospital and doesn't have money to buy that machine for the hospital. And then we have the supplier who needs to supply the machines but do not have enough capital to have those machines in stock. So who should take the loan?
Thank you for a very good question. Actually, both can take loans. If the supplier has a need to store machines or even purchasing on demand, they can come and get a loan, because sometimes it's for stocking just generally, or sometimes it's directly to supply somewhere. So if you're directly supplying to somewhere, it means you come and borrow the purchase order financing loan, LPO loan, because you have a contract, you have LPO to supply somewhere. So that one you can supply. That one, as I said, is 7 days. You get your yes or no. But if you are stocking, just you have a store, you're stocking, you can also get either working capital loan that I've explained, or you can get a term loan. Term loans are for investing, and term loans for working capital. Because for working capital, because you want to see maybe how you reduce the loan, so you can take a term loan for working capital. So both can get a loan. Karibu-san.
Thank you for that. And one more question from anyone? If there's no question, then by show of hands, right, I just want to know that from the session today, do we feel like we have a better understanding of these access to finance opportunities that are there, and has our fear for even going to a bank and having a conversation with them, has it reduced even a little bit, if I can see by show of hands? Okay, which for us is great. I think these are the kind of conversations that we as a project are trying to facilitate. Please, as I said, we'll be around. You have seen the faces here. Please feel free to reach out to us, ask any questions. And I think for us, what we will only request is really, let's not be afraid of finances, and let's have those conversations with the necessary stakeholders. There's a lot that the private sector can do for health. If the intention is there, the willingness is there, the motivation is there, and the only thing missing is finance, then we have stakeholders who are here to help. So thank you so much for joining us today, and let's keep talking. Karibu. I forgot, thank you to the panelists for their time today. Thank you so much, Dada Rema, Ibrahim, Deus. Thank you for your time.
Thank you so much, FHM Engage. Let's make another round of applause for FHM engagement. Now we are moving for another session for MDH. MDH, you are most welcome.
Habari za mchana. I can see that the room is not well balanced. Karibuni sana kwenye forum ya MDH. For those who are seated on this side, please, if you need, you may take, the middle side seat. There are very good seats here, and you'll be able to, to be close to the speakers. So just a few minutes as we try to rearrange ourselves. My name is Machumi. I'm with the MDH, and I'll be facilitating this session. We welcome you to the MDH Forum with the title and focus on HIV drug resistance in Tanzania. This is a very important topic that we are going to be discussing today, and we know that as a country and globally, a lot of gains have been made on HIV/AIDS control, and as per the UNAIDS, we expect, or we are striving to control the epidemic by 2030. By focusing on three main targets: the first 95, second 95, and the third 95. So identifying 95% of clients who are living with HIV, and then ensuring that 95% of them are put on care and 95% have had virus suppression. So we know that through the efforts of different partners, Tanzania has made a lot of progress. And if you visit, for those who have access, the DHS2, which is the main reporting structure for the Ministry of Health, we have already identified around more than 1% of HIV, 90% initiated on treatment, and more than 96% virus suppressed across the country. So today, and as the title says, we have four main speakers. The first one is Dr. Boniface Juru. Dr. Juru, who is seated, maybe you can wave your hand, yes. Dr. Juru is a senior researcher, and he will provide research perspective on HIV drug resistance in Tanzania. And this comes from a recent study that was done, particularly in the area of prevention of mother-to-child transmission settings. After Dr. Julu, we'll have Dr. Josephine Mwakisambwe. Thank you. Dr. Josephine is an expert on advanced HIV disease, and she will share some experience on a program implementing HIV drug resistance testing in the program settings. And she will also touch base on some program intervention that can prevent HIV drug resistance occurrence. And following that, we have another presenter, part of the panel, Dr. Mohamed Jallo. So Dr. Mohamed is with the U.S. Centers for Disease Control and Prevention, CDC, and he's the Chief of Science and Surveillance branch at CDC. And he will share a CDC perspective on HIV drug resistance and surveillance of HIV drug resistance in Tanzania. And the fourth speaker is our CEO, Dr. David Sando. Dr. David Sando will provide a high-level perspective of MDH's impact on healthcare in Tanzania, but he will also share the national perspective on drug resistance in Tanzania. So that said, I welcome you to listen. After the presentation, we have a session for discussion, question and answers. I invite you to actively contribute. Please note down your questions, suggestions, clarifying questions and the like, so that we can have a meaningful discussion. We are distributing some copies of the content that will be presented, and those includes a compendium of abstracts. On this conference, we have about 33 abstracts that have been presented, and some of them will be presented later. So feel free to go through as presenters presenting. But we also have many reports on HIV drug resistance that you can skim through as the presentation are happening. Without further ado, let me invite Dr. Juru. Please welcome to the podium for the first presentation.
Thank you so much, Dr. Machumi. Distinguished guest, good afternoon. So allow me first to introduce myself. I'm Boniface Julu, working for Management and Development for Health. And I'm standing in front of you just to share the research finding that we did back 2019. And this is about HIV drug resistance among HIV-infected pregnant women. And as you can see from the slide, this was a collaborative study. We received funds from CDC, and MDH was an implementing firm in this research, together with the MOH and the PRH. And the study itself is all about the prevalence, pattern, and the risk factor that are associated with HIV drug resistance among pregnant women. And that's the outline, but what is key from this slide is that in this implementation assessment, we had two sub-arms. We involved women who were newly diagnosed, seropositive, and those who were already on ART for at least 6 months and above. So I also need to register my appreciation from the early morning presentation, that some of the presentation in the morning, they actually made my presentation easier, and I don't like to reiterate some of the information that we have already heard from early morning presentation, but at least I'll touch base on some of the key information. We appreciate the commitment and the coverage of PMTCT in Tanzania, which actually now stands at 93% coverage. But with all kind of coverage we have, we also have a national commitment of actually reducing HIV transmission from mother to child below 5% come next year. But again, we have a long-term wish that we have to reduce transmission of HIV from mother to child by below 2% come 2013. That's a wish, and that's a fact that we have as we speak. But HIV drug resistance stands as a single most threat to all this success. We have heard again from morning, the vertical transmission stands at 11%. So this is actually a threat that if we cannot address the single most threat to what we have gained so far, we can actually all be pulled back from the success that we are celebrating now. And this was a reason now to conduct this study. So we wanted to know how big is this problem, the HIV drug resistance among HIV pregnant women. But again, what are the patterns? What are the association of the drug with a specific type of drug resistance? And last, we wanted to know what are the driver behind that they could actually contribute with the emergency of HIV drug resistance. So this slide here is just to take you back that we conducted this study way back 2019. By that time, our country was actually the transition phase from the TLE, tenofovir, lamivudine, and efavirenz that were actually our mainstay on HIV care and treatment towards the TLD, tenofovir, lamivudine, and dolutegravir. So this is just to appreciate that much as we have moved our client from TLE to TLD, we still have quite a number of ARV in the NRTI and the RTI, which are in combination with DTG. But again, we thought in-house that it's better to understand what are the drivers which could actually lead to emergence of HIV resistance. And this is from the clinical perspectives. We may have quite a good number of factors that are hinged from the virus itself, the health system factors, the drug issues, drug-drug interaction. But again, the most key is those factors which are actually hinged to the client itself. And I would like to emphasize here that adherence is very key. Of all the factors that could lead to emergence of HIV drug resistance, the factors that are related to the client itself, they're actually key. And here I would like to remind of our 3 big R. The first, that you have to use the right drug, the prescription. 2, the right dosage. And last, the timing. You have to take at the right time, interval, and duration. So as I said, our study involved pregnant women, and we actually categorized in 2 arms or assessment. The first arm involved those who were newly diagnosed at the ANC or PMCT clinic, and those who were already on treatment for at least 6 months and above. So what does now the pre-treatment drug resistance imply? This is a situation where you are not already initiated on ARV, but you have a resistant strain with element of mutation. This is what we refer to as pre-treatment drug resistance. And what is the most information from the pre-treatment drug resistance is actually it informs the healthcare provider what ART regimen would be appropriate to initiate this particular client. So that's the most message that we get from the pre-treatment drug resistance. As opposed to the acquired drug resistance, the second arm of the assessment, this is a situation where you are infected with an HIV which is susceptible to all ARVs. But in the course of taking ARV, you acquire the resistance. That's why it's called acquired drug resistance. So those were the 2 sub-assessments that we conducted concurrently. I would limit myself to explaining, I don't want to teach you molecular biology, but at least please pay attention to what I'll try to explain from these slides. The coming discussion will actually hinge from this slide. So how do we classify HIV drug resistance mutation? We classify into 5 levels. The first level is where the strain that you are infected with is actually susceptible to all ARVs, and you are scored a green, as you can see from the screen, susceptible. And then next to that, you have a strain which score potentially low. You can still go with the ARV, but with an alarming connotation. Similarly to the low level, but if you have a strain which score intermediate, that's a time where you should start thinking, changing or substituting the ARV to a particular client. And the worst scenario is where you have the strain where the virus is completely unsusceptible. It means the drug, they have no any harm to the virus. And it means you have to stop immediately and change or substitute to effective regimen. So what were our results? As I said, with regards to the pretreatment drug resistance, we had quite a number of variables that we looked at. Similarly for the PDR, but what is most important here for the ADR, that 90% of our clients whom actually participated in our assessment, they were in the first default first-line ART, tenofovir, lamivudine, and efavirenz, and 10% were in the second ART regimen. We also looked on the other factors that are from literature. They have shown elsewhere being associated with emergence of HIV drug resistance. Now, what we found in both two assessments, with regards to pretreatment drug resistance, more than a quarter of 459 who participated in that assessment, they had at least even a single resistance mutation which could confer resistance to a drug, which is high. You can imagine, they are not already initiated on ART, just about to be initiated. More than a quarter, they had resistance strain. And that's a number. 126 out of 459, they had resistance mutation. On the other side, the acquired drug resistance, more than 3/4 of the 553, they had resistance mutation. These are the mothers by then who are on ART, who are on care and treatment for at least 6 months and above. And more than 3/4, they had resistance mutation. And the WHO advocate or insist that if you're doing acquired drug resistance, it's better you had a time point interval and you have 6, 12, 36, 48 months. And in our study, we are able to note that the clients who were on ART for at least between 25 and 35 months, they had a higher level of resistance mutation as opposed to those who were above 36 months. And we speculate that probably due to EAC, enhanced adherence counseling, and switching, substituting, it actually contributed to a slight decline between 25, 35, and 36, 48 months. Now, looking at the pattern, and here it's also very key if you could actually follow what we are saying. With regards to pretreatment drug resistance, we found tenofovir and lamivudine, TDF or 3TC, substantial amount of clients, they were resistant to this drug. And this is to bring a point, if you remember my initial slides where I was comparing 2019 before and after, we are still using these drugs in our current practice. They are already showing level of resistance. Similarly, with the acquired drug resistance, tenofovir and lamivudine, the same, but of course here with escalated number of clients who were already resistant to that drug. The figure that I'm showing in green under pre-treatment drug resistance is just a message that by the time that we are shifting our client from TLE to TLD, substantial amount of clients, almost 80%, they could still be initiated on efavirenz based, but we actually shifted to TLD. Similarly for the ADR and similarly for the high resistance level. We also looked on the factors. In our study, the most commonly finding that we got, that condom use was protective, meaning that 65% of clients on the pre-treatment drug resistance, they were actually protected by 65% by just using condom. With regards to ADR, being on the second line, particularly lopinavir boosters with ritonavir, tenofovir, and emtricitabine, together with the HIV subtype A, they were both protective. So what are we making conclusion from our findings? We observed both the high level of resistance mutation in both arms, pre-treatment drug resistance as well as acquired drug resistance. And the most affected ARV were actually within the NNRTI and the NRTI, and the less on ARV within the protease inhibitors. What recommendation can we make from this finding? First, to policymaker, what we are saying that moving now with the improving quality of service, we have heard from the opening remark a day before yesterday and today, that we are saying, based on the finding that we got, that HIV drug resistance testing should be considered as routine, especially when you have mothers with the high viral load, and those who are on the ART and they got pregnancy with the high viral load, they should be tested immediately for HIV drug resistance. So that's number one. Two, to the healthcare providers and implementing partners, we saw the factor that they actually associated with the emergence of drug resistance. We insist that EAC should be intensified on this factor, but of course without forgetting other strong pillar during ANC. Three, to the researchers and probably even the policymaker, we now using TLD, tenofovir, lamivudine, and the DTG. But we have just seen from the previous slides the level of resistance with regards to these two drugs, tenofovir and lamivudine, which are used in combination with the DTG. So what we are trying to advise here, if we could have a periodic systematic surveillance in the era of TLD, that will give us a quick baseline information on how the DTG is currently performing. Last, this is very key when we are discussing in the morning about the trying to cut the transmission of HIV from mother to child. Mothers with high viral load, with a high level of resistance mutation, you can imagine the fate of the newborn. And especially if the mother is on the second line, where those drugs on the mother second line, they are first line on the pediatric HIV, you can imagine. So what we are saying here is that if we could do further research to understand what magnitude of resistance mutation they are passed over from mother to a newborn, that would be great, because they actually inform a lot of clinical practice. So this is what we actually are trying to share with you and see if we could actually convince that we should now consider HIV drug resistance as part of routine care so that we further attain the last mile toward HIV epidemic control come 2030. And this is just to acknowledge the team. We also, again, acknowledge the funding from CDC, PEPFAR, technical support and financial. And I tend to say, let us join hands with MDH to make sure that everyone is healthy. Thank you so much.
Now let's welcome Dr. Josephine Mwakisambwe for a perspective on the program. Josephine, karibu.
Thank you very much, Dr. Machumi. Good afternoon, everyone. MDH? Bado. MDH? That's better. I'm aware of the incredible honor and the privilege that I have to stand on this podium in front of giants. And I'm happy that there's so many familiar faces. So we're sharing our work on implementation of HIV drug resistance in routine care in our facilities. Work which was mostly very collaborative and a team effort from NACP, regional and council health management teams, our healthcare facilities where we do the work, regional implementing partners that support us, and the DRMDH field teams that do most of the heavy lifting. And we will take you through just the scope of what we do, or MDH's portfolio for HIV drug resistance implementation, and then provide an overview of what we do, what we are doing, lessons learned, challenges, and we'll forge a way forward. Now, MDH implements a very comprehensive HIV prevention, care, and treatment program across 4 regions in the country, and about 48% of the clients in care in the country are supported in MDH sites. Viral load suppression is currently at 98%. About 98% of our clients are on first-line ART, and just 2% are on second-line ART. Of note, we have 45 clients that are already utilizing third-line ART. We're talking about HIV drug resistance testing, which is a prerequisite for third-line ART initiation, and just looking at our clients on second line, 93% of them are suppressed, which means about 7% have possible virologic failure and need these services. Why they need these services is so that they can also attain the 95% viral load suppression amongst themselves, so that we can achieve the coveted epidemic control and really sustain that through the undetectable is equal to untransmittable modality. MDH has both an above site role and as a regional partner during the implementation of HIV drug resistance. And for instance, in policy development, we collaborate with NACP and region and council health management teams to recommend the best ways that we can integrate HIV drug resistance that Dr. Julu has clearly shown is required in the country into routine practice. So this involves revision of guidelines, development of, say, SOPs, etc. And we additionally support HIV drug resistance testing, which is currently being conducted in Temeke and Mbeya zonal labs. So we support these 2 facilities to provide drug resistance testing commodities, and we redistribute and make sure that drug resistance testing is fluent. Additionally, we collaborate with other stakeholders for capacity building for human resource for health. So this includes capacity building, material development, training of national mentors, national TOTs, and also definitely capacitating our facilities as well. And this is also coupled with on-site technical assistance, including mentorship and supportive supervision. And this is across the country. And in the past quarter, for example, we were able to support 10 regions in this regard, but that is coupled with monitoring and evaluating, making sure that all eligible clients are receiving this service and up to the quality of care that we so much yearn for. I'll take you briefly through the implementation approach that we're utilizing, and most of this is MOH recommended. At the facility, once a client is suspected to have second-line failure, they have to be reviewed by the district team, And if the adherence is deemed optimum, this client is referred to the regional hospital where a thorough client review investigation is done, and HIV drug resistance sample is collected for those that are eligible. And these are processed at the lab, and the results from the lab are emailed to the National Third Line Committee, which will review this client and develop recommendations. Now, this National Third Line Committee meets weekly, and these meetings are normally virtually. So for those clients without PI resistance, they resume back to their mother facility, while those that are deemed eligible for third line initiation, such is dispensed. The goal is that this whole circle will take a month, but we've observed that adhering to this means increased client burden with regards to the time that they need to travel to the facilities for reviews, and additionally costs of living while they're seeking this service, and most of the times they travel with their treatment supporter. Additionally, this will take more than a month because of the transit to the facility, mobilizing the MDT, making sure that the CTLC will meet weekly, and we did have a short-lived supply gap with regards to the darunavir. And so with innovations, we are happy that these challenges brought about an innovation that sprouted in Kagera, where we are implementing person-centered approach to provide HIV drug resistance services in an outreach basis so that these clients are having a reduced burden while we are adhering to the national guidance. So among the unsuppressed clients, we had a total of 700 samples, about 70% of which were successfully processed, and and this will be the focus of my discussion. So these samples came from mostly 15 to 24-year-olds, and these are clients already on second line. Most were females and had been in treatment for 5 years or more. Most of these clients, more than 50%, were already on abacavir-based regimen, and tenofovir-based regimen were also utilized about 30% of these clients. And with regards to PI utilization, this was at 64%. Now, in this, we're seeing that in line with what Dr. Julu has presented, and in this category, we were careful to categorize clinically important resistances, which were high level and intermediate level resistances to be categorized as high, as yes, there are mutations. So we're seeing that there are high mutations, and this is expected within these clients because they have already failed first line, and particularly in NRTIs, with amtricitabine and lamivudine maintaining partial activity, and hence their continued use in their guidelines. Of note is the low resistance between darunavir, lopinavir, and atazanavir drugs. This one also shows the 5 levels that Dr. Julu was talking about. We are seeing, again, variable resistance levels between abacavir and other NRTIs, and we need to be on the lookout for lamivudine and amtricitabine for their use. So we've learned through implementation that there is limited access to HIV drug resistance testing, and this is particularly because we are having clients living in hard-to-reach areas. There's limited trained personnel providing these services. Additionally, we are having challenges with suboptimal adherence and counseling due to either client factors, psychosocial and economic barriers, limited means to monitor adherence, and stigma and discrimination still continuing within our facilities. Additionally, we are still continuing to see limited knowledge and skills, which impedes timely identification of these clients. There is limited access to lab monitoring tests, particularly because these clients have been in care for a while, and we want to make sure that their creatinines, their liver function tests, their lipid profiles are up to par, which is another challenge we have. Additionally, there is slow-moving coordination between the region and district management teams, and we've noticed and addressed HIV drug-resistant needs with regards to clients that have had prior ARV exposure, pregnant women, and those that are on first line but unsuppressed. We're recommending implementing partners, facilities, regional and council health management teams that we need to forge a collaborative and person-centered approach to increase HIV drug resistance access. For example, the Kagera model that has shown to work. Additionally, we're talking about optimizing quality of ART service delivery, which includes really tying our clients with the healthcare provider and the peers so that we can improve adherence within this group of clients. Additionally, capacitating both our facilities through the multidisciplinary teams, which we have seen increases the comprehensive nature that they use to identify clients, but the MDTs themselves need to be capacitated and also support them so that they can operationalize HIV drug resistance implementation timely and with good quality. Additionally, there is a need to strengthen how we monitor implementation to make sure that all eligible clients are receiving these services, but more so because we have a fragmented system that does not fully encompass HIV drug resistance cascade. To the policymaker, we would like to request that they increase access to lab monitoring tests, and with the cost-sharing activities that are happening in our facilities, we're looking forward to seeing how we can maximize access to these facilities, either through the Health Insurance for All Act that is currently being discussed, but we need to really put our heads together on this, and additionally policy revision so that we can expand the unaddressed need for HIV drug resistance testing. MDH, you are listening. Thank you very much.
Thanks a lot, Josephine. I think you have utilized your time well. Let's see. Yes, now let's welcome Dr. Mohamed Jallo from CDC to give us a perspective on HIV drug resistance and surveillance in Tanzania. Dr. Mohamed, karibu sana. We are short of time, so 10 minutes, please. 10 minutes. Yes.
Good afternoon. Once again, my name is Dr. Mohamed Jallo, and I am the branch chief for science and surveillance at the CDC office here in Tanzania. Today, I'd like to talk about the support that the US CDC is providing to the government of Tanzania, mostly through MDH, but other partners that we support to strengthen HIV drug resistance surveillance in Tanzania. So we have 4 areas of surveillance for HIV drug resistance that we support. You've heard about some of these already from the prior presentations. The first is around routine clinical surveillance, which is also linked to enhanced adherence counseling, EAC. Second is the antenatal clinic surveillance, ANC surveillance, that you heard from Dr. Julu. And third is the population-based surveillance. Fourth will be key population surveillance, and I'll talk about these as well. And last but not least, lab-based surveillance. So for routine clinical surveillance, you've already heard about this. I'm not going to spend a lot of time on it. The population here of focus is diagnosed PLHIV who are already receiving ART. And the criteria is those who are on second-line ART regimen, but they are unsuppressed and they've gone through multiple rounds of enhanced adherence counseling, EAC. And the approach here is that CDC provides support to the government of Tanzania through our implementing partner, MDH. And as they mentioned already, they both conduct HIV drug resistance testing, but also provide capacity building nationally, at the Temeke lab, at the lab in Mbeya, as well as at the national lab. Currently, the national lab, was going through some transitions, and right now they're not doing HIV drug resistance testing. But our hope is that the national lab will also be reactivating their HIV drug resistance testing program. And I think much has been said on this topic already, so I'll move on to the next form of surveillance that we do. And the next one, I think you've also heard a lot about this one on ANC surveillance. I don't need to spend too much time on this, and I'll likely just move on. But just to mention that this work is really, really important because it has implication for how we consider potential expansion of HIV drug resistance surveillance going beyond what is being done right now. I think it's really important to understand both PDR and ADR among pregnant women and breastfeeding women. And you know, we stand ready to continue to support the government of Tanzania to expand HIV drug resistance surveillance. But as you know, those policy decisions lie with the government of Tanzania. So now I'll talk about additional surveillance efforts that have not been presented so far. The first I want to highlight will be the population-based surveillance that we're doing to understand HIV drug resistance in Tanzania. So you may have heard about the Tanzania HIV Impact Survey, correct? How many people have heard about the THIS? Okay, well, if you haven't heard about it before, now you'll hear about it. So the THIS is a nationally representative cross-sectional survey that is conducted across every single region on the mainland of Tanzania, plus in Zanzibar. And we collect a number of biomarkers including for HIV drug resistance. And we use that to be able to understand population level drug resistance. So this is not just necessarily looking at clients who are already aware and diagnosed and on treatment, but it's looking at the entire population of people living with HIV, including those who may have HIV, but they're not even aware of their status, right? And those who may be aware of their status, but maybe they're not on treatment. So that's the advantage of using this population-based approach from the survey. The last Tanzania HIV Impact Survey was conducted in 2016, 2017. And we learned a lot from that. So we have a level of baseline data to compare with. And now we're in the middle of doing the second Tanzania HIV Impact Survey, 2022-2023. So from that survey, we're going to get a lot more information in terms of population level dynamics with regards to HIV drug resistance. And we're very excited about this. MDH is a key partner in doing this work. And ICAP is the primary partner for the THIS, but MDH will be responsible for the HIV drug resistance testing. So because we care about equity, and you know, it's important to understand what's happening at the general population level, but we also have to make sure we understand HIV drug resistance among key populations. For example, people who inject drugs, female sex workers, and other groups in Tanzania, regardless of their HIV status awareness or their ART use. So we have the biobehavioral surveys that CDC is supporting through numerous partners, ICAP, but also University of California at San Francisco, UCSF. But these are partners that are meant to support the government of Tanzania. And with these biobehavioral surveys, what we call the BBS assessments, we're able to understand HIV drug resistance among various key populations. We've completed one round of BBS right now on the mainland, in this year in 2022 in Mwanza, Mbeya, and Dodoma. And these assessments have now been expanded to 2 additional regions on the mainland, Dar es Salaam and Arusha, and a new round of BBS in Zanzibar, in Unguja, and in Pemba. So the last, and this is a very exciting project, and it's one that we're also working very closely together through our partner MDH, support government of Tanzania, is to look at DTG-based drug resistance. I think Dr. Julu talked about the introduction where we went from TLE to TLD, right? Most clients now in Tanzania, I would say almost all, are on some kind of a DTG-based regimen. So we don't expect to see very high level of mutations to DTG at this point, but we need to get a baseline understanding now. And I think, as you mentioned also, this drug has been used with other drugs that already have shown to have patients developing mutations towards those drugs. So for this lab-based surveillance approach, the focus will be clients who have been on a DTG-based regimen for at least 9 months. And regardless of going through EAC, because normally clients have to be unsuppressed, they go through EAC multiple rounds before they go through HIV drug resistance testing. So what we're doing here, we're expanding the pool of clients that we look at so that from a lab-based approach, so long as you're unsuppressed, meaning you have greater than 1,000 copies, your sample will be eligible to go into the random selection of samples that we will collect from 9 labs, 7 labs on the mainland, and these are large labs, zonal labs that are covering multiple regions, and then 2 labs in Zanzibar. So this is a lab-based approach. We then randomly select these samples, do the genotyping, and then link their results with the epi data that we have for these clients, their age, gender, the ARVs that they're on, their CD4 count, whether they're, if it's a woman, if she's pregnant or not, and other demographic and epi information that will be collected. We're expecting to have a sample size of 1,200, and this sample size is large enough to produce, representative samples for Tanzania for both adults and then also to an extent for children. So I'll stop there. These are the main efforts that the US CDC is supporting the government of Tanzania to strengthen capacity for HIV drug resistance surveillance. We think this is a really, really important area. We can have a lot of people living with HIV on ART, but if we're not paying attention to drug resistance, then we're gonna have a lot of challenges in the future. So the more we're able to actively understand HIV drug resistance and the dynamics and patterns and the predictors of HIV drug resistance, if we can be on top of that, then we can have policies that align with making sure that we're providing the best care to patients, that we're making decisions which patients need to receive, which drugs, and when to switch patients to different drugs based on their acquiring of different mutations. So I just want to stop here and appreciate and thank our partner MDH for the great work that they're doing, and also appreciate the government of Tanzania for the excellent work that Tanzania is doing with the HIV program. Asanteni sana.
Thanks a lot, Dr. Mohammed. You have stuck to the 10 minutes given, and that gives us an opportunity to have more discussion towards the end of this. And thanks for providing perspective from the CDC. I think some of the surveillance activity that were going on were not known to some of the partners, and this it's encourages to hear that we have already started to look at DTG to create a baseline so that in the near future maybe we can protect it, because as you presented, we can see that some of the medication that are in combination with DTG are already having significant amount of resistance. Our final presentation will come from Dr. Sando, who is presenting on the national perspective of HIV drug resistance. But he will also discuss a little bit about the MDH impact on the healthcare at large in Tanzania. How does MDH work impacts various facets of health services in the country? Dr. Sando, karibu sana.
Thank you, Dr. Machumi. Good afternoon. Habari za mchana. Yeah, I probably have little to say now after the 3 presentations, which have covered much of what I wanted to say. But I want to say thank you actually for a very good presentation. And so as Machumi have introduced me, I'm Dr. David Sando, for those who doesn't know me. I work for MDH, and MDH is a local NGO here in Tanzania, so it's not international. Some people confuse us. I've been to, meetings where people, refer to us as an international organization, but we are not yet there. But, we are proud local NGO, and we are happy to work with all the international and learn from the experience of the international organizations to be able to foster really delivery of quality care here in Tanzania. And so we are really, based here in Tanzania, and our focus is on supporting the government effort to establish a resilient and effective healthcare system in our country. And our priority areas actually include infectious diseases, non-communicable diseases, and including mental health. So we have projects on MAT, for those who have heard about methadone clinics. We are one of the pioneers, and we keep actually really supporting the government efforts around that area. Maternal, newborn, infants, children, and adolescents health. We've worked and we continue to work around nutritional services, global health securities, issues to do with outbreak and disaster management, research and implementation science, as you've heard from Dr. Julu, that is only one of so many implementation science that we're engaged in, and also surveillance activities. So I won't go into the details, but as you can see, in each of those areas, actually within the service delivery, the number of people living with HIV/AIDS who are actually taking care in the facility that are supported by MDH. The first presenter or the second presenter mentioned 4 regions, but 4 regions, those are the ones that we are actually being supported through CDC, but we are also in other 6 regions where we implement Afya Yangu together with Deloitte as the technical lead. We support delivery of care in Morogoro, Iringa, Njombe, Mtwara, Lindi, and Ruvuma. And we are also in 7 regions actually under Global Fund, where we are really supporting community TB, identification of TB cases. And we also have a mechanism where we are supporting strengthening of laboratory services in the country. And in line to that, we are supporting establishment of surveillance, strengthening the surveillance systems, both in mainland and also island. So really we are cross-cutting. We are working in all system blocks to make sure that we complement the government effort for achieving really an effective functional healthcare system that can respond to the need of the Tanzanians. So, going to HIV-DR, and the topic, of the day is HIV-DR, and why HIV-DR? So this morning we had a very good discussion around epidemic control. And one of the key issues that comes out is, how Tanzania is positioning itself to achieving epidemic control by 2030. So this is an ambitious goal, and as a pathway towards reaching that, we've actually, aimed to achieve 395 by 2025. And in order for us to achieve that, then we need to make sure that we reach out to 95% of people who are living with HIV/AIDS, test them and make sure they are aware of their HIV status. Make sure that 95% of them are linked to care and are given ART on time, and 95% of them are being sustained and achieve viral suppression. So the third 95s, and I've seen most of the time we talk about viral suppression, and we are happy that it looks like it's probably one of the first 95 to achieve. But from there going forward, if we really have to achieve the epidemic control, the last 5% is going to be a big mountain to climb. Bending that curve to achieve that will require us to be innovative, will require us to have functional and effective system of identifying resistance among our patients, addressing them on time, improving adherence. So the topic that we are discussing today is really paramount when it comes to achieving epidemic control. As we get more people in care, now, as you've seen from MDH experience, about 7%. So when you talk about 7% of the total PLHIV in the country, you're talking for close to more than 30-40%, like 40,000 clients or people living with HIV on ART who are susceptible to HIV drug resistance, who are actually showing signs of viral unsuppression. So how do we, as a nation, what is happening and what is recommended? So globally, WHO have actually provided a framework, and this is the framework that also NACP and all other, partners in the countries are actually, using as a guidance towards, our effort in addressing HIV drug resistance. And within this framework, one of the major milestones is making sure that we have the National Action Plan on HIV drug resistance. This is a strategy that governs all our efforts. So all the partners and stakeholders in the country should be working towards, a unified approach that must be defined and structured well under this National Action Plan. And then there are also directions on forming national technical working groups that are specifically guiding and advising the country on efforts to addressing HIV drug resistance. Monitoring of HIV drug resistance is very important, but also the surveillance. You've had a number of HIV drug resistance surveillance. Those are key to informing the fight against this epidemic, but also establishment of the National HIV Drug Resistance Database. So in a nutshell, when you talk of the National Action Plan on HIV drug resistance, the other second pillar is the monitoring, which we have what we call early warning indicators. These are the indicators that should be integrated within the routine monitoring system, and they are used as a gauge to actually tell us how our program is doing. These are procs that tells us on how are we faring as far as HIV drug resistance emergence from the clients who are receiving ART care. And then the surveillance, as they have been mentioned, we are talking of acquired HIV drug resistance among adults and children, the pre-treatment HIV drug resistance among infants. This is something that we haven't had, but it's being proposed that we should also start to think about our infants and whether we need to put in place a mechanism to also really understand what is happening as far as the HIV drug resistance among infants. The pre-treatment also resistance among adults who are initiating ART, and also the PrEP users. So the PrEP user who are diagnosed with HIV/AIDS, it's important that we start thinking on, how to put, a surveillance among them so that we are able to understand whether, what are the sort of emerging HIV drug resistance mutations among the PrEP users. So going into the details of the National Action Plan, what is it? And you might be asking yourself, what are the key components of this plan? So one of it is really to iron out some of the high impact interventions that are actually should be implemented to prevent emergence and also respond when the HIV drug resistance comes up. And these are some of the activities that we've been discussing, quite a number of them. I think Dr. Josephine took you through some of the things that we are doing actually to make sure that we are preventing or responding to HIV drug resistance. And these are geared towards improving retention, adherence, viral suppression, so that actually the clients are able to stay longer without really switching or developing any mutations. Then monitoring, this is where we need data, and the surveys are very important here. Encouraging research and innovation, there's a push now towards coming up with clear research priority around HIV drug resistance and integrating them within the national research priority agenda, so that the research community is made aware of what are the research priorities within these areas and are motivated to actually take these as part of the priority research agendas. The laboratory capacities, as it is mentioned, as we stand now, we have two main labs that are actually doing HIV drug resistance. We have the MDH Temeke lab that is taking majority of the HIV drug resistance in the country, and we also have the Mbeya Referral Hospital. So all the samples across the countries that are being, for patients who are moving to third line, they have to be sent to these two labs. But where are we? Is this, WHO also recommended to have the accreditation, lab that is accredited to actually doing HIV DR, and in terms of the governance also. So going into the details, when you look at actually the laboratory capacity that I've mentioned, the viral load testing now has been decentralized to all the regional hospitals. So we have regional hospitals now capable to do the viral loads, and we've seen as a result of that, the turnaround time has really gone down, both for viral load and also HIV early infant diagnosis. But we still have important gaps. As I've said, we don't have, up to now, in-country lab that has been accredited for HIV drug resistance. There are now processes actually to accredit the MDH Temeke, and I know that the national lab is also lodged its request to WHO also for accreditation. So we hope that MDH, we have had discussion with WHO, Geneva, and also support from the ministry. One of these days would be actually accredited to be able to provide HIV drug resistant services at the standard that are acceptable at the international level. But also screening of eligible clients. I think as Dr. Josephine mentioned, there are still cumbersome and bureaucratic mechanisms that are used to identifying and making decision around who should actually receive the HIV drug resistance test. That needs to be addressed. It's a big gap. And as a result, we are seeing a longer time taken between when the tests are taken or when a client is identified to when the results are obtained. In terms of the research and innovations actually in the country now, we have started to see a number of studies that are coming up on HIV drug resistance. Dr. Julie has just shared one of the study that we've done. A couple of studies that have come up this year. There's one that was done by Shimba et al., which looked at the prevalence of and pattern of HIV drug resistance in patients with suspected virological failure in northwestern Tanzania. Another one, which was done by Barabona et al., also coming up sometimes late last year, which looked at the pre-treatment and acquired drug resistance. This was at Muimbili here in Dar es Salaam. And another one also, which was published last year, end of last year, which was done by Trevor et al., which looked at the pre-treatment and acquired HIV drug resistance among PLHIV in 4 African countries, Tanzania included. And when you look at the findings of these studies, all of them are really pointing to the fact that the mutations rates are growing fast. We are seeing now patients who are actually, even though we are giving them 3 drugs, but in real sense, they are in monotherapy. When you have drugs, especially when you look at the pre-treatment, so these are the people that have not yet started treatment, but 1/3 of everyone, who, starting ART, so we're talking of, let's say, 1 out of 3 of those people who are newly diagnosed with HIV, already they have mutations on the drugs that are being used currently, which means that if they are put on treatment, so if they have mutation to 1 or 2 drugs, if they are given 3 drugs, probably it's only 1 drug that is working. So what we are seeing is we have many people who are actually on monotherapy and not triple therapy. So even the DTG itself that we are very proud of is now being subjected to work on itself, and we are posing a huge risk of losing its longevity in use, because as we are actually, depending on it as the monotherapy, the chances that it will grow some mutations and speed up it being ineffective, it's really a big risk. So we really need to be mindful of that. At the results, when you look at the surveillance, I think the surveillance that have been mentioned here by Dr. Mohammed, one key, proposal that as MDH we're thinking that's important is the introduction of HIV drug resistance to any pregnant woman with high viral load. Now the cost of viral load testing is coming down. We have other modalities. We are finding ways where the cost can actually go down to less than $100, which means that we should probably be able to afford it. And for pregnant women who are starting ART in 2nd or 3rd trimester with high viral load, there's no really time to wait until you do the EAC, and then the high viral load is risk also to the infant. So we are proposing and we're suggesting, recommending that we should think on, really at least doing HIV drug resistance among women with high viral load for the sake of actually preventing the transmission to the baby, so that we start them on the treatment that we are certain it will work, based on the susceptibility of the strain that they have. Also, the HIV drug resistance among PrEP users is important actually to monitor the prevalence of emerging HIV drug resistance among PrEP users. So some of the recommendations I've said, first, we have an outdated national strategy for HIV drug resistance. I don't know how many of you knows, but this is the strategy or plan that was developed, almost 10 years ago. It is outdated. We need to actually review that in the light of all the evidence and experience that we've had. I'm glad we met with the NACP team this morning, and they're excited actually to see how we can collaborate to review that, to make sure that we have one strategy that kind of, govern our effort as a nation, to streamline actually the process of testing for HIV drug resistance. As I said, we are also recommending routine HIV drug resistance among pregnant women. Also considering HIV drug resistance testing coming down, then instead of waiting for the second virological failure to move to the second line and third line, all clients with virological failures to actually have HIV drug resistance, irrespective of whether they are first line or second line, so that we are able to detect, because the levels of mutations are high, we are able to intervene well ahead of time. And last is actually surveillance of HIV-DR among PrEP users. Thank you so much, and yeah.
Asante sana, Dr. Sando, for that perspective. And now we have about 15 minutes of discussion. But before the discussion, I would like to thank all presenters for the perspectives that you have shared. Just to recap a little bit, Dr. Jule has, if you have missed the presentation, but Dr. Jule has shown us that from the study that was done among pregnant women, we had around 28% of resistance, pre-treatment drug resistance, and around 79% of acquired drug resistance for those who are already on treatment. And of course, Dr. Jule recommended intensification of enhanced adherence counseling, but also systematic surveillance to protect, the existing potent medications, which I'm happy that Dr. Mohammed clearly told us what CDC is doing to support surveillance in the country. But also Dr. Josephine presented the program perspective and identified some of the challenges that the clients that we serve are facing, including psychosocial barriers, and some, suboptimal adherence due to the same reasons, psychosocial challenges. And I think there are some recommendations from both Dr. Julu and Dr. Josephine, policy recommendations, but also some programmatic recommendations such as, real-time ART service delivery in order to reduce the risks of drug resistance. Many thanks to Dr. Mohammed. I think you clearly mentioned, you clearly underscored the need to get a baseline understanding of DTG. We know that since implementation of DTG as a part of combination with the other two medications, popularly known as TLD, we have seen an increase in viral suppression among our clients. Now, when we hear that in some of the clients, they're actually taking one medication, DTG, while the first T and L are already having a resistance, hiyo inatutisha sana kwa wale ambao tuko kwenye current treatment, si ndio? So we are happy to know that there's something that's being done to protect this one effective medication. And Dr. Sando giving us the perspective at the national level. He mentioned that MDH's goal is to complement the government's effort in addressing the needs of Tanzanians. But I think he posed some several questions. How is Tanzania positioning itself to achieve epidemic control? And actually, a very important discussion, the last mile, how are we positioned? We are speaking of the 95, 95, and 95, but maybe the most important thing after achieving that target is how do you address the last 5%? We know that it's going to be hard. It is already becoming harder, but looking at issues like drug resistance is what is going to put us in a position to address the last mile. So that said, I would like to open up for some questions in the minutes that we have. I think we have something like 10 plus minutes. So some hands. Yes, so we start with Dr. Mary and then move on to the two behind and then on your side. Karibu.
Thank you, Dr. Machumi, and
so
congratulations.
Just before you question, just mention who are you addressing the question to? And just mention that I'm addressing my question to a certain presenter. Karibu.
Are you excluded or included?
I'm included.
Asante sana. I'm Mary Mwanyika Sando, and I'm pleased to be here. I would like to congratulate our panelists for really exciting and enriching presentations, but also commend MDH and appreciate the support of our funders, CDC, to enabling this to be possible. So I have two questions, rather for clarification from Dr. Julu. If you can, please help me with the understanding, as you had noted, that when you see women with adherence improving in terms of like declining the drug resistance that you identify, you think it is because of the adherence, etc. I'm wondering whether it is the same women that you're referring to, and if it is the same women on the same medication, if you can please clarify. I think you get the point where I'm coming from. And the second point is on my second question, is if you can also explain with regards to condom use, as you had noted, for those pre-drug treatment, condom use had a great potential of reducing the drug resistance by roughly 65%. And likewise with those that are already on treatment. I'm wondering whether on that aspect you have been able, or you do tease out in terms of, is it condom use among married couples, considering the fact that usually married couples would not use condoms, and even those that are not, in the long run, would not use condoms. I would appreciate clarifications. The last goes to Dr. Mohammed. Thanks a lot for giving us more confidence that CDC is key on embarking into expanding drug resistance surveillance in the country. I'm wondering if infants are included in the plan, much as you would be looking at, as Dr. Sandra also alluded to, that about women who have high viral load, etc., pregnant women would be subject to drug resistance testing. I'm just wondering, for those few infants that are still born with HIV, whether they will be part of this surveillance in the beginning, or they would be considered later. Asante sana, Dr. Machumi.
Asante sana, Dr. Mary. We have a couple of hands over there. Yes.
Thank you very much to the panelists for the good presentations on how we are integrating HIV drug resistance. Actually, the current HIV drug resistance testing that is ongoing has given us more light as to whether we really need to have second-line ART. We have had some cases where clients that have been on second line for so long, actually, we are not requiring that. And even the need for switching that to them to third line was not important. So I actually really agree with Dr. Sando's recommendation that for any client that needs to be, is having virological failure, it's important to have HIV drug resistance testing. But every time we come into discussion like these ones, we are faced by the issues of cost. And what I just wanted to hear from Dr. Sando is how are we going to go around this issue of costs when it comes to HIV drug resistance to all of the clients that will be having a high viral load. Thank you.
Thank you. The next one? Yes, the next behind, yes. And then we'll go to, yes, Shukrani. Yes, Karibu.
Asante. Good afternoon. So my name is Francis Kazoba. I work with EGPAF as the pediatric advisor in Manyara region. I would like to thank the panelists for the good discussion. And thank you, Dr. Sando, for mentioning the key populations who have to be tested for ART resistance. You mentioned about the infants and the people who are on PrEP, as well as the high-risk group. So, but one group is left behind, which is the pediatric population. And I would like to ask Dr. Ju probably to at least give us the vision. Where do you see this population in the next 5 years? As you studied people who have been on TLE and went to TLD, the pregnant women, but our children are exposed to ART first at when they are intrauterine, before birth, and when they are being born to a woman who had not been on ART, they started on AZT, 3TC, and nevirapine. It's the second line. I mean, it's the second drug. And probably if they're confirmed to be HIV positive, they'll be started on another formulation, ABC3TC, and probably nevirapine as well, or opinavir. And now we have the TG10 as well. So we have a population of people who have been on multiple formulations within a short time of period. So they've been on more than 4 or 5 formulations, but they have not been like given priority in the studies that have been done. So I'd like to ask, where do you see this population in the next 5 years? Thank you.
Thank you. So let's go to Shukrani, and then we take that as last question for a discussion. Karibu.
Thank you. I'm Dr. Shukran Bwaga, working with MDH, and I would like to take this opportunity to congratulate the panelists for the good presentations. And my question goes to Dr. Julu. As we have seen that about 25% of clients who were involved in pre-treatment drug resistance had resistance mutations, which were noted. So I was asking Dr. Jule, do you recommend pre-treatment drug resistance research on non-pregnant women and men who, in one way or another, we know that their interactions had impact also in PMTCT? Thank you.
Thank you. So let's take that the last question for the first round, and we'll get the response. And after the response, if we still have time, we'll take another round of questions. Karibu.
Thank you. My name is Victor Zibukia. I'm a medical doctor and also a community IT officer from MDH. So my question goes to Dr. Juru. We are very aware that on pre-treatment exposure may be coming from the PrEP use, which composed of tenofovir. So in your research, were you able to get the difference on those who are exposed? Are they on PrEP services or just general population? And on the implementation part, I'd like to ask Dr. Sando, do you have any alternative means on how we would combat this resistance by changing the use of PrEP services from oral PrEP to alternative which are vaginal links composed of dapivin and also injectables of carbohydrate, if I'm not mistaken? So maybe we change from use of, on our method of PrEP services from oral to injectable and the use of vaginal link. I think this would help on combating the resistance. I've heard also there is a guideline set by the WHO by July which there is instruction how we can use this injectable and also vaginal links. Thank you.
Thank you. So we'll pause there and have time to discuss. Thanks a lot for asking the questions. And I think we'll first invite Dr. Jewel because most of the questions are, yeah, maswali mengi yamekuja kwako, which shows that this is a topic of much interest to majority of us in here. So Dr. Jewel, Karibu, I think there is a question to you from Dr. Mary, from my colleague here, I didn't catch your name, but also from Kazoba and Rosie Bukia. Karibu Dr. Jewel.
Asante Dr. Machumi, lakini pia niwashukuru wote. Thank you so much for those who asked me a question. They are really very pertinent to the topic, and actually this is why in-house MDH we said probably we should use even this forum to make sure that we all actually understand and move as one team. So let me start with the most difficult question from Dr. Mary Sando. First, thanks so much. So to start with, the study itself, the study design, it was a cross-sectional. So we had only just one data point. So it's not a trend. Now, coming specifically to the decline of drug resistance mutation, as I said, yes, if you read the WHO recommendation, the way we report acquired drug resistance as opposed to pre-treatment drug resistance, you have to analyze at different time points. So they advise at 1 year, 2 year, and 3 years and above. So when we did sub-analysis in-house, we actually noted that between 6 and 11 months, at least a year, actually it was almost the same. But we actually noted a spike in ADR who were within 25, 35, they were above, across all the three ARV class, the NRTI, NRTI, and the PI. But again, looking at those who were 36 and above, we also a sharp decline across all the three drug classes. Now, given the fact that it was a cross-section, we just had a single data point. We actually just compare within the data set. We didn't have any option to compare with other studies. So we are just actually limited our interpretation within the same data finding that if you compare those 2 points, 25, 35, and above 36, we saw actually a sharp decline of drug resistance mutation for those mothers who were 36 and above. And that's why we actually speculated probably it was due to enhanced counseling or switching from the failing drug. So that applies the same to condom use. So again, it was a question that did you use condom during your last sexual intercourse? Again, because it was also a cross-sectional, so it's just a single data point. But I have to be very clear here, it's actually association. I'm glad that we have the experts here in epidemiology. It was not Dr. Mary Sand, it was not a causal effect study, but rather just to see whether there's association between the condom use and the emergence of acquired drug resistance. And what we observed, the 65% protection, it was actually from the statistical model that we used. But it's a typical association, but not rather the causal effect study that if you change X, then you must also, Y must also change. So it was not in that fashion. Yes, pediatric ART, 5-4 formulation. I agree, my brother. Sorry I mixed up your name, but I know in this morning we had a very specific topic on HIV, pediatric HIV with EGPAF. Yes, I've been in this field for many years. I know the hurdles that the pediatric are facing. Crashing the drug, you understand? From a full tablet to a half to a quarter, but no one is actually very certain how much in terms of the active ingredient goes to pediatric. So I fully agree that we have actually a bit of a problem with the ART formulation. Now, where do I see this, this group, special group, and linking from what Dr. Sando was proposing? Yes, we still have less information with the HIV drug resistance among this group. And I think if you remember our last recommendation that when the mother fails, and especially those who are on second-line ART, the PI-based, because the PI-based is our mainstay in our second-line regimen. And very unfortunate, the same regimen, which are on the second line for the pregnant breastfeeding women, they are the first line regimen for the pediatric. Now you can imagine, if the mother is already resistant with the PI, which are the first line for the kids, that's worse, because we are not doing routine HIV testing for the pediatric. So even the selection of the appropriate ARV for the kids become very compromised. So it's a challenge that we take as a point. And moving forward, if you heard from Dr. Sando, much as we want to review the HIV drug strategic plan for the country, these are the issues that we really need to take into consideration. But again, even to sum up, in the national guideline for the pets, irrespective of the regimen, whatever, they are supposed to test for HVL. So the third question is PDR, 25%. How do we take into consideration testing non-pregnant and their couples? Yes, so we don't have, currently we don't do the HIV drug resistance testing in this, but I take it as a challenge that much as these mothers or couple, they are not already initiated on ERT. First, as I say, the pre-treated drug resistance occurs in many scenarios. You may be exposed prior to full regimen, during PMTCT, or interrupted ART. So having such high level of 25, 28%, if you read the WHO recommendation, anything above 10%, that's where you should also change the regimen. And this is why the nation actually took initiative to move from tenofovir, lamivudine, and efavirenz as our mainstay, going to TLD. But as we have heard that we saw some amount of substantial resistance mutation to other two drugs which are in combination with the DTG. And this is why now we are saying that having a baseline on the DTG performance before it's actually being practiced for a longer time, it will be much better, because even the DTG itself, as we speak, it's not like a single magic bullet. There are evidence elsewhere where the resistance mutation for DTG are actually compromising. We have DTG and ratutrelvir altogether in our third line. Ratutrelvir is the first generation of INST. Okay? The DTG is the second generation. The worst scenario that the resistance mutation from the ratutrelvir, which is the first generation of the integrase strand inhibitor, they can actually cross over and bring resistance to DTG. And here, we just talk pregnant mother who were attending PMTCT clinic. It does not mean that we do not have this resistance mutation. Why? This drug, they're available even from the private market. And people, they just go. And when it comes to social life, engaging in sexual activities, it does not discriminate. So much as we see a population base, a huge decline of HVL, which we're all proud of, But we should not celebrate 100%. We have to celebrate while watching that even the DTG itself is not 100% safe with resistance mutation. So better have this baseline as what we have heard from CDC and what Dr. Sando proposed. The last is from Victor. Yes, if you report the level of drug resistance with regards to pre-treatment drug resistance, there are 3 levels. The first level, you report the overall HIV drug resistance irrespective of ART prior exposure. So that's the first category. And that's where we got the 28%, more than a quarter. The second level is just you categorize those who have been exposed to ARV by whatever means, whether they were on full treatment regimen and then they stopped, we call it interrupted, or PrEP, or post-exposure prophylaxis, as well as
Dr. Jule, I think
PMCT.
in the interest of time, if you can wind up, and just as an announcement, we have been informed that lunch will be ready at 1:45. So we have an extra few minutes to finalize this discussion. So Jule, please finalize that, respond to the last question, and then we'll go to Dr. Sando and then Dr. Mohammed.
Thank you. I was actually winding up. So yes, with that observation in Victor, we take care that TDF has shown level of resistance, and we think that when with those surveillance that we have had moving forward, with those who are suppressed, we shall have a very concrete information with regards to TDF, which is a backbone in the TLD regimen. Thank you so much.
Thanks a lot. Thanks a lot, Dr. Julu. So, Dr. Sando, maybe there's a question on the issue of cost. Yeah, maybe if you can respond to that, and one other question. Karibu.
Yeah, thank you. So, thank you again for the question. It's very actually good one. Do we need a second line ART? Issues of cost? How are we going to actually do about this? Maybe just before I answer this, the issue of first line, second line, and third line really came about, to address the issue of, this was a population-based, and it's still a population-based. So we're making assumption that most of our people are susceptible, they have virus which are susceptible to particular drugs. So whoever comes, we give them, we subject them to that first line, ART. And if they don't do well, we move to second line. If they don't do well, we move to third line. But here is an opportunity now for those that who are not doing well to say, can we know which drug will work best to you? In that case, it means we forget the issue of first line, second line, and third line. We can even rotate some of the drugs that are out now. If we do the susceptibility and we find that, oh, this person is actually more susceptible to TLE. So if the person has no mutation on TLE, even though we've removed the favirance, maybe we could consider that if the person is actually resistant to DTG. So the advantage with doing HIV drug resistance to this specific, let's say for pregnant women with high viral load, is that now we would be able to choose and recycle drugs to find which of the drugs that are available would be more beneficial to that woman. So that's an added advantage, and I think as the cost keeps going down, we are more likely going to a point where we can actually decide. The doctors would be, given an opportunity to decide from an array of all the drugs available, whether it's second line or third line, which of the drug available is more effective, and that would be, what will be prescribed. So I'm saying this as, being futuristic, trying to see in the future and the advantage of having this technology around. But when you talk in terms of the cost, assume now, from the results we've seen, almost 30% of people infected with HIV, they have the pre-treatment drug resistance, which means out of those, let's say, who are starting ART, assume 1 out of 3 has a certain type of resistance. So, for example, let's say out of 1 million people that we have on ART, close to 300,000, they have either a mutation on tenofovir or lamivudine. And we saw that, I think even in abacavir, we saw like 10%. So we're talking of, let's say, 100,000 people. So all these drugs are the drugs that we are buying, but they're not functioning. It's a waste. Suppose the program is buying, tenofovir and lamivudine to 200,000 or 300,000 clients, which is ineffective. In a sense, it is a waste. So when you're actually looking at the cost, we're now losing more than if we could have actually subjected these people to HIV drug resistance. Because we are seeing, and this is very scary, because even for those that we are seeing the HIV drug resistance, the high viral load, the unsuppressed one, those are the extreme cases. It means now we have the suppressed ones who is only the DTG which is working. So we can't tell because the viral load is going down. It's fine, but the two drugs are not working. It's a waste. It would have been even more beneficial to only give them one drug and reserve that cash for something else. But now we have fewer who are actually who are being unsuppressed. So subjecting those who are being unsuppressed to HIV drug resistance testing makes more sense because you are saving more. Think about the productivity cost. So these are the people who become sick, and because of the sickness, they're not actually producing to the level that we would assume that as an individual would contribute to the national welfare. So there is also a loss in productivity. There is also now good news, and thanks to CDC, an effort where we are trying to now find the mechanisms where the cost of HIV drug resistance test is going to go down significantly. So the cost of the test is going down, plus the other factors that I mentioned. If we are able to do a thorough cost-effective analysis, we would most likely conclude that subjecting each client with high viral load into HIV drug resistance test is more beneficial, is more cost-effective than waiting for somebody to go into second line, and then after second line, that's when we decided to do this. So if you do that, you're actually saving all the money that we are wasting by subjecting this person over maybe a year, 2 years, 3 years to drugs that are less susceptible, and only to find that if we could have done maybe HIV drug resistant tests maybe a year or 2 years before, this person would have been put on the right drugs and make this person able to contribute economically and also socially, and that will be beneficial to the government. So I think the issue of cost it's definitely a good point, but with right amount of evidence and data, we might be able to even estimate what would it mean in terms of the gains, the health gains vis-a-vis the economic cost that the country might get. At MDH, we're now starting to think whether we could even pilot this, so we can actually maybe do some sort of like a small scale implementation science in 1 or 2 facilities, and then collect all this information in terms of the cost, in terms of the healthcare systems acceptability, so that later on when we are actually making a policy recommendation, we have all these informations that are needed for policy decision. I think that, and then the second question on the PrEP users, alternative means to prevent HIV drug resistance. I think this is really theoretical question. I don't have a straightforward answer. Whether you take it, orally or you take it through other mechanisms, I think adherence is still an issue here, and one needs to be actually clear. And when we say the HIV drug resistance testing or surveillance among PrEP users, I think there are 2 or rather maybe 3 types of resistance here. So we are talking of the resistance that maybe the PrEP user might develop because of exposure to ARVs. It could be, a transmitted, resistance that the PrEP user who is not HIV infected, because, that is the condition for them to be given the PrEP, they acquire HIV maybe from a person who already have a resistant strain. So they could have a transmitted resistance. But for resistance that are due to poor adherence to ARV intake, the PrEP uptake, I think that does not go away if you take it maybe through injectables or vaginal, whatever. Like, I think the issue of adherence will still be there, but, you know, probably more innovative ways of looking at, and I think our experience when we started PrEP, it was more facility-based, but now we are seeing, you know, interest for community-based. And I'm actually now, you know, trying to think that MDH, we tried what we call condom dispensing machine. So if you go to certain hotspots like bars, you might find there's a, you know, a vending machine where some of the KVP could just go there at midnight at any point and get their condom. And the thinking is now, could we also integrate PrEP? Because we know these people, so if we find them, let's say in some of these hotspots, we just give them a code, and, you know, once a month they can be going there, entering the code, and they get, you know, their PrEP from a vending machine that is situated within their localities. It's not within the facility. They don't have to meet with anyone. And that could also, you know, improve their uptake, because sometimes they're not sick, and, you know, they don't see a reason why they should come to the facility. And the issue of quality also comes in, because I think one of the biggest problems we are facing here is not really initiating them on PrEP, is how do we prepare them? How much information do we give them and support to make sure that the behavioral change become part and parcel of the PrEP? And I think our programs have been more pushy towards, you know, numbers, getting more on PrEP, reporting the numbers, rather than the quality of the service, so that we are, you know, we approach this holistically in terms of preparing them, understanding that whatever their lifestyle, the risks that they're taking through their lifestyle, so that as they take PrEP, they are also, you know, undergoing transformation in terms of reducing their risk behaviors. Yeah, and I think...
Thanks, Dr. San. I think we are quickly running out of time, even the addition time. Just for the 2 minutes that we are remaining with Dr. Mohammed, there is a question from Dr. Mary, I think, regarding including the pediatrics in the surveillance. Maybe you can respond to that. And some few additional questions that came in. Karibu.
Okay, so I think I only have one question, which makes it easier for me since we have lunch coming up. With regards to what has been done for infants on a routine basis or even on a surveillance basis right now, nothing has been done that I am aware of. However, with the lab-based approach that we're talking about, you know, we are going to allocate some of the sample to children, but that's age 0 to 14, right? So it's not going to produce a large sample of infants, especially since there's a criteria that you must have been on a DTG-based regimen for at least 9 months. So, you know, the sample of infants, those under 12 months, are going to be quite small. But I do think it's very, very important to look at infants, especially those infants whose mother are HIV positive and who had one or more HIV drug resistance mutations. I think that it's a very clear group that we have to start looking at and understanding treatment outcomes in this group. You know, so maybe taking an implementation science approach. I'm looking at MDH here. I'm looking at our colleague from CDC who are also here, thinking about some kind of implementation science approach to start looking at this on a small scale. And based on what we learned from that, you know, maybe have discussions with the government, because as you know, if we want to make this a routine practice, it has to be a policy decision from the government of Tanzania. And, you know, I think we need to share the evidence first with the government to inform their decision making.
Thank you. So we understand that we had more questions, and we are happy to respond to those as we get our lunch. We received a question from our colleague from Domroma. We'll have a discussion to respond to that. But before we close, I would like to just give Dr. Josephine maybe 10 seconds, just to be, you know, there's no question that was geared towards her, but just one, you know, neno moja, based on all this discussion. Karibu.
Thank you, Dr. Machumi. I'm liking this gender thing being prioritized. Let's do that for lunch as well. Yeah, so mostly I just like to thank everyone who's here. I'm seeing a lot of other implementing partners, EGPA, FAGPAI, I'm seeing AMREF, I'm seeing HJF, and I was to thank them for also submitting the HIV drug resistant samples. We've seen considerable increase for the past quarter. So I wanted to thank them and kindly remind them that we're in this together. And then additionally, I'd like to thank Dr. Sarakikia for being innovative with the Kagera model. It has really been a game changer for us. And then finally, I'll start thanking everyone. Lakini, this one deserves a recognition. David Temba, all the data I have included is mostly coordinated and supervised by Temba, so asante sana, and Dr. Nzovo as well. Thank you for the guidance and the insights in making this presentation. Asante Talumba. God, thank you everyone.
Asante sana. Yeah, so just one big round of applause for presenters. Tunashukuru sana for this topic. Sorry we have gone a little bit beyond time, but ni kwa sababu lunch ilikuwa jawa tayari anyway. But now is ready. Tunawashukuru sana. Karibuni MDH. Our office is in Mikocheni. For those who have who are new in Dar es Salaam, Mikocheni kwa Nyerere. We'll be happy to continue this discussion, you know, as scientists, but also as program implementers. Asanteni sana, muwe na mchana mwema.
Asante, we go for lunch break, and the next session we start from 2:30. And we'll be having two forums. For Hendrik Jackson will be here, and the other forum will be at Mikumi for St. Joseph. Karibuni.